Now, let's talk about the different working classifications. So, ideally, what we follow is the ISSHP classification, that is the International Society for Study of Hypertension in Pregnancy, and that defines gestational hypertension, preeclampsia, eclampsia, superimposed preeclampsia on chronic hypertension, and chronic hypertension. These are the five categories which are according to the ISSHP guidelines. So we'll be taking it up one by one. What is gestational hypertension now? So hypertension that develops after 20 weeks of gestation, that is what is known as gestational hypertension. There is no proteinuria, there is no other factor which takes it towards the diagnosis of preeclampsia, and there is purely and only hypertension with the cutoff of equal to more than 140 for systolic and equal to more than 90 for diastolic. Now, this is very important that this rise in BP returns to absolute normal within 12 weeks postpartum. Okay. So, the beauty of the fact is this, that gestational hypertension is a retrospective diagnosis. So, unless you follow the woman up for 12 weeks postpartum and then take a BP recording saying that it is normal, then probably you're not able to qualify for gestational hypertension. Okay, so this BP, which was raised in the gestation, should return to normal within 12 weeks of postpartum. Now, approximately 25% of women with gestational hypertension develop superimposed preeclampsia or eclampsia, and they can also have a high recurrence rate in the next pregnancy. So, these need to be followed up closely even after they deliver in the postpartum period, and they should have a 6 monthly or annual checkup with their physician in order to keep their BP recordings in check. So it is also referred to as transient hypertension. So transient because it is only for a short period of time, and after that it resolves. So develops after 20 weeks, absence of proteinuria and other corroborative factors, returns to normal within 12 weeks of postpartum, definitely is a high risk factor for developing preeclampsia or eclampsia, and it is also referred to as transient hypertension. This was all about gestational hypertension. Now, let's have a word about preeclampsia. So, what is the minimum criteria? A BP recording of equal to more than 140 and or 90 after 20 weeks of gestation. And yes, there may be proteinuria, and if there is, it is equal to more than 300 milligram per dl over a 24-hour period. Or if you do a bedside dipstick, it is equal to more than 1 plus. Okay. So this is the minimum criteria for diagnosing preeclampsia. A BP recording equal to more than 140/90 after 20 weeks of gestation, and a proteinuria of equal to more than 300 milligram per dl over 24 hours, or an equal to more than 1 plus on dipstick. Now, what are the additional criteria? So previously it was thought that hypertension along with proteinuria is what is preeclampsia. But later we got to know that it is not that simple. Even in the absence of proteinuria, there can be other markers along with raised BP which can point towards the diagnosis of preeclampsia. So what are those? Number one, a serum creatinine equal to more than 1.1 milligram percent unless it was known to be previously elevated. So this is not the case in a woman who is known to have a raised serum creat prior. It is only when it is in accordance with the high BP recordings and there is no other explainable cause for this raised serum creatinine. There we take the cutoff as 1.1 milligram percent. Then secondly, a platelet value of less than 1 lakh per cubic mm, an elevated AST or ALT. Previously we used to call it as SGOT and SGPT, but now it is aspartate transaminase, that is AST, or alanine transaminase, that is ALT, right? But how much elevated? We know that these enzymes do get elevated in pregnancy, but if they are more than 2 times the upper limit of normal, more than 2 times the UNL, then they will be considered as a criterion for preeclampsia. Next, if there is persistent headache, or there is any cerebral or visual disturbance, or there are focal defects in vision, like focal deficits in vision, which we know as photomata, then again we should consider a diagnosis of preeclampsia. And the last is pulmonary edema. Okay, so even in the absence of proteinuria, if a raised BP recording is associated with any of the following, that is a raised serum creatinine more than 1.1 milligram percent, platelet count less than 1 lakh per cubic mm, elevated AST or ALT more than 2 times the upper limit of normal, persistent headache or cerebral or visual disturbances or scotomata and or pulmonary edema, you have to know that yes, this again is preeclampsia. Now, we have two different kinds of preeclampsia. One is the non-severe preeclampsia and other is the severe preeclampsia. Before these nice 2019 guidelines, this non-severe preeclampsia was also called as mild preeclampsia. But now we know that the new terminology is of non-severe preeclampsia. So, severe preeclampsia, we derive the criteria from the Chesley's criteria of severe PET. And what is that? A BP where the systolic is equal to more than 160 mmHg and or the diastolic is equal to more than 110 mmHg. That will be coming under the diagnostic criterion of severe preeclampsia. Second, oliguria, a renal output of less than 400 ml in 24 hours. That is what qualifies for the criterion of severe PET, or less than 30 ml per hour. Okay, less than 30 ml per hour or less than 400 ml in 24 hours. Again, a criterion for severe PET. Third, whether the woman has cerebral or visual disturbances such as headache or scotomata or persistent visual disturbances, that again comes under severe PET criteria. Next is pulmonary edema. Epigastric or right upper quadrant pain. Yes, this is a very important and a clinching sign which tells you that there might be a subcapsular hepatic hemorrhage or even stretching of the Glissen's capsule, and the woman complains of persistent right upper quadrant pain. So sometimes it just slips out of your diagnostic criteria. You confuse it with labor pains or anything like that. But if pain is specifically located to right upper quadrant, or epigastric. Why have I said epigastric? Because the left lobe of the liver, the left lobe of the liver basically lies in the epigastric region. So if it's an epigastric pain, don't confuse it with simple acidity or retrosternal burning or a case of GERD, etc. But you should remember that it might be because of stretching of the Glissen's capsule over the left lobe of the liver. And if there is any visible evidence of hepatic dysfunction as far as the biochemical parameters are concerned, if there is thrombocytopenia, the cutoff is less than 1 lakh and it is not 1.5. Why 1 lakh? Because there is some amount of dilutional gestational thrombocytopenia, so we have to account for that. And yes, a fetal growth restriction. Now, this is a new criterion. Previously, we did not include FGR into the criteria for severe PET, but now it is known that in severe preeclampsia, there is an onset of uteroplacental insufficiency, which definitely would result in fetal growth restriction, and more so in early onset preeclampsias and less so in late onset preeclampsia. But definitely, it is one of the criteria for diagnosis of severe preeclampsia. Okay, it's just tabular classification. Non-severe diastolic less than 110 should be. Yes, severe equal to more than 110. Proteinuria is mostly traced to 1 plus. In severe, it is 2 plus or more on dipstick. Headache, visual disturbances, upper abdominal pain, that is epigastric pain, or a right upper quadrant pain, oliguria, convulsions. They are all rare in cases of non-severe preeclampsia. Now, these convulsions may be present in severe preeclampsia, but definitely it will then be called as eclampsia. Okay, so the risk of convulsions is more in case of severe preeclampsia. Creatinine again is normal in non-severe. It is elevated in severe preeclampsia. Thrombocytopenia, more chances of it to be present in severe PIH. Liver enzyme elevation, again, it is minimal in non-severe, marked in severe preeclampsia. Fetal growth restriction, again minimal in non-severe, obvious in severe preeclampsia. Pulmonary edema, also high risk in severe preeclampsia. So this is how basically you classify preeclampsia as non-severe or severe, and you do not use the term mild anymore. You have to keep it in mind. Okay. So we just talked about early onset preeclampsia, right? So there is an early onset preeclampsia and there is a late onset preeclampsia. Now, what is early onset? When the onset of hypertension is before 34 weeks of pregnancy, right? So 34 weeks is the cutoff. And there is another term we also know about, the early onset FGR, that is fetal growth restriction. So when I'll be taking a class on FGR, I'll be telling you that there is something called as early onset FGR and there is a late onset FGR. But there the cutoff criterion is 32 weeks, whereas in preeclampsia, the cutoff criterion is 34 weeks. Now, in early onset preeclampsia, the maternal complications are more severe. Also, it runs the risk of low birth weight, fetal growth restriction, and iatrogenic prematurity. So what is late onset preeclampsia? Onset of hypertension after 34 weeks of pregnancy. So remember, to diagnose early onset and late onset, the cutoff is 34 weeks. The maternal complications are less severe and low birth weight and fetal growth restriction is less common. So definitely an early onset preeclampsia where the pathophysiology started and kicked in pretty soon is going to have more repercussions on the maternal as well as the fetal and neonatal health. Now, I told about proteinuria and the diagnostic criteria. So, there should be a significance of proteinuria. Now, what do we consider as significant proteinuria? So, a urinary excretion of more than 300 milligram of protein, and this proteinuria is mostly non-selective. Okay, non-selective proteinuria. But first, of course, albumin will come into picture, and then later on anything else. So this proteinuria, it is there in a 24-hour period. This level of 300 milligrams, that would be considered as significant proteinuria. Now, once significant proteinuria is established, further quantification is not required as proteinuria does not have prognostic value from management point of view. So once you understand that this has happened, there's no need to follow it up. Like there's no need to do a daily, a bi-weekly protein levels or urine protein levels, because once you've diagnosed that yes, proteinuria is there, it does not have any prognostic value. What does the HDP Gestosis scientific group recommends? It recommends to do a urinary dipstick, or you can do a spot urine protein creatinine ratio. Okay. Significant proteinuria can be assessed when the urinary dipstick is equal to more than 2 plus. And if you talk about the spot protein creatinine ratio in the urine, so it should be equal to more than 30 milligram per millimole. So these are the two cutoffs. Significant proteinuria on dipstick is equal to more than 2 plus, and spot urine protein creatinine ratio equal to more than 30 milligram per millimole is what qualifies as significant proteinuria. However, the gold standard of assessing proteinuria is still a 24-hour urinary protein, but definitely it has its own limitations. It is more cumbersome, and you might not have that much amount of time in your hand, and you have to decide it on a spot sample rather than doing a total 24-hour urine protein assessment. So after reading about gestational hypertension and preeclampsia, let's talk about eclampsia. I told you the moment seizures set in, it is straight away eclampsia. So eclampsia is the additional presence of convulsions, which are grand mal seizures. Now grand mal is an old term again. We call it as GTCS, so generalized tonic-clonic seizures in a woman with preeclampsia that is not explained by a neurologic disorder. Okay, so any woman convulsing in pregnancy is considered to have eclampsia unless proven otherwise. Now, eclampsia is a Greek word which literally means shining forth or a lightning strike. Okay, eclampsia occurs in around 0.5 to 4% of patients with preeclampsia, and cases of eclampsia usually are seen postpartum. They occur within 24 hours of delivery, but approximately 3% of cases can be diagnosed 2 to 10 days postpartum. That means there are something called as late PPE or late postpartum eclampsia. Okay, so ideally it is seen within 24 hours of delivery postpartum, but you may have an episode of convulsion even up to 10 days postpartum, and still it would qualify for the diagnosis of postpartum eclampsia. Now, eclampsia again can be mild. I mean, it is not a very wonderful way of classifying it, because when the seizures have set and everything is really severe, but you can tell about the prognosis of the woman based on something known as the Eden's criteria. So, if Eden's criteria is fulfilled, that means the woman has a poor chance of survival. She's at the high risk of morbidity and mortality. And what all comes under the Eden's criteria? So, a coma of more than 6 hours duration, a temperature of more than 39 degrees Celsius, which is suggestive of either a setting up of pneumonia in the patient or even a pontine hemorrhage, a thermostat failure. And when this happens, it tells you that there is a poor chance at survival. A risk of cerebral hemorrhage is there when systolic BP rises equal to more than 200. a pulse of equal to more than 120, which is suggestive of acute heart failure. When anuria or oliguria sets in, it suggests renal failure. A respiratory rate more than 40 per minute, suggesting lung failure, pneumonia, or ARDS, and more than 10 fits, that qualifies for status eclampticus. When these are present, we know that the woman is landing in MODS, or multiple organ dysfunction syndromes. It is affecting the lungs, it is affecting the brain, it is affecting the heart, it is affecting the kidneys, and that is when we know that this woman might not have great chances of surviving this crisis. Okay, so this is about the Eden's criteria of eclampsia. The next comes superimposed preeclampsia. So what is superimposed preeclampsia? It is the occurrence of preeclampsia in woman who is already diagnosed with chronic hypertension. Suppose a woman is hypertensive pre-pregnancy, okay, or a woman, we know that raised BP recordings are noted in the first trimester itself. So it is because of chronic hypertension. But she also develops signs, symptoms, and biochemical parameters suggestive of preeclampsia later on. Then it is diagnosed as superimposed preeclampsia. So when there is a new onset proteinuria, again the cutoff is the same, equal to more than 300 milligram per dl over 24 hours in a hypertensive woman who did not have proteinuria before 20 weeks of gestation, or there is a sudden increase in proteinuria or blood pressure, or the platelet count drops to below 1 lakh in a woman who is hypertensive with proteinuria before 20 weeks of gestation. So all of these are criteria for you to diagnose superimposed preeclampsia. Now the last one is chronic hypertension. I should not say this is the last one. This last one, according to the ISS-HP classification, but there is another entity called as HELP syndrome, which we'll be reading. So first we go through chronic hypertension. Again, a BP of equal to more than 140 and or 90 either before pregnancy or diagnosed before 20 weeks of gestation. Now, this diagnosis of raised BP recording before 20 weeks of gestation, so one, you have chronic hypertension in your head. And other, I told you that in molar pregnancy specifically, preeclampsia can be set off in the early gestation, and then you need to differentiate these two. Okay. Or it can be defined as a hypertension first diagnosed after 20 weeks of gestation and persistent after 12 weeks postpartum. So now you understand the fact that why I was stressing so much in gestational hypertension, that it's a transient hypertension that resolves within 12 weeks postpartum, and then only you can give the diagnosis of gestational hypertension, because even if this set off after 20 weeks of gestation, but if it persisted equal to more than 12 weeks postpartum, it is not gestational hypertension, it is what? It is chronic hypertension. And with the current trend of childbearing at an older age and the epidemic of obesity, the incidence of chronic hypertension in pregnancy is expected to rise. So we need to be more and more aware of the management protocols regarding chronic hypertension. Yes, so I told you about HELP syndrome. What is HELP syndrome? It was first described by Weinstein et al. In 1985 as a severe form of pre-eclamptic liver dysfunction. So it's an acronym that stands for H for hemolysis, EL for elevated liver enzymes, and LP for low platelets. So that is how HELP comes into picture. And yes, so you can see hemolysis on a peripheral smear, liver dysfunction, and a low platelet count is what constitutes HELP. So, how do we diagnose HELP syndrome? Again, we have to demonstrate each component of HELLP. So, first, hemolysis. Now, to diagnose hemolysis, we require at least two of the following. Either an abnormal peripheral smear, that means not the normal discoid shaped RBCs. Instead, we have fragmented RBCs in the form of schistocytes or helmet cells or Burr cells, which are telltale signs of microangiopathic hemolytic anemia or MAHA that happens in HELP syndrome. Second criterion would be an elevated serum bilirubin, a level of equal to more than 1.2 milligram percent, or a low serum haptoglobin, because lots of free heme is going to be released and the haptoglobin levels are going to be low, or a significant drop in hemoglobin levels which is unrelated to blood loss. That means that there is an ongoing hemolysis, because if there is no blood loss, there must be an ongoing hemolysis which is contributing to the significant drop in hemoglobin levels. So either at least two of these for an abnormal peripheral smear, an elevated serum bilirubin, a low serum haptoglobin, and a significant drop in hemoglobin levels is what is required to diagnose the hemolysis component of HELLP syndrome. The next is elevated liver enzyme. So an AST or ALT at least twice the upper limit of normal, I told you, then only it will be classified as a preeclamptic liver dysfunction, or an LDH of more than 600 international units per liter. And low platelets, the cutoff again is 1 lakh per cubic mm. So when these components are fulfilled, it is called as HELLP syndrome. We have another classification system for HELLP. Now we classify it as by two modalities. So one is the Mississippi classification, other is the Tennessee classification. Now the Mississippi classification tells you about the severity of the syndrome based on thrombocytopenia. Whereas on the other hand, the Tennessee classification system tells you whether it's a complete HELLP or it's an incomplete HELLP. Now, ideally what happens, the class 1 Mississippi, we think that class 1, class 2, class 3, so the class 3 would be the severe most. But this is the reverse in case of a Mississippi classification system. So class 1 Mississippi is the most severe, but the platelet count is less than 50,000. Okay. Class 2 Mississippi, platelet count is between 50,000 to 1 lakh, and class 3 Mississippi, platelet count between 1 lakh to 1.5 lakh. So which is the most dangerous? Class 1 Mississippi HELLP. Agreed? So this is based on the severity on diagnosing the platelet count. And what about the Tennessee system? So if all the criteria are fulfilled, like a raised liver enzyme, a low platelet count, along with LDH more than 600 with hemolysis, it's a complete syndrome. But if one or two components are fulfilled of the HELLP, whether there is hemolysis, elevated liver enzymes, low platelets, not all the criteria are fulfilled, then it is called as an incomplete HELLP. So this is the Tennessee system of classification of HELLP. Now when you read Williams Obstetrics, there is a concept of delta hypertension. Okay, so what is delta hypertension? Delta hypertension is a sudden rise in the mean arterial pressure later in pregnancy. It also signifies preeclampsia even if the BP is less than 140/90 mmHg. So all this while I've been telling you that the cutoff is 140/90, right, for systolic and diastolic respectively. But if the woman has a BP say of 128/86, so it is well beneath the cutoff. But the baseline was say 90/60, and there is a sudden shoot up of the mean arterial pressure. And how do we calculate the mean arterial pressure? So basically it is diastolic BP plus 1/3 the pulse pressure. And what is pulse pressure? It is systolic minus diastolic. So that is how we classify and quantify mean arterial pressure. And if there is a sudden rise in the mean arterial pressure, even if the absolute value is less than 140/90, still the woman carries a risk of preeclampsia, and these women may even develop eclamptic seizures or HELLP syndrome while still being normotensive. So these are a handful of enigmatic and elusive cases you have to diagnose based on the mean arterial pressure findings, and you do not rely on the absolute value of blood pressure either for systolic or for diastolic.